So good evening, everybody. We'll be starting in a few minutes. Let some more people join, because every time we are starting around 7:07 or 7:10, something like that. So we'll just wait for 1 or 2 more minutes and then we will start. So we have 21 attendees now. I think, Dr. Kavita, we can start. Okay.
Okay.
So good evening, everybody, and thank you for joining. And today we are going to have a session on simulation-based learning. And Dr. Kavita, she's very kind enough to prepare this session for us at a very short notice. And she is currently professor and head of the department, Christian Medical College and Hospital, Ludhiana. She's a fellow in reproductive medicine from CML, from Ludhiana, from Vellore itself. Very sorry, Christian Medical College. Sorry, Ludhiana itself. And she's also faculty for curriculum implementation support program and level 1 simulation instructor and Deputy Hub Lead, India Global Surgery Research Collaboration, University of Birmingham. So it's a pleasure having you, Dr. Kavita. Please, you can start the session.
Okay, thank you, Dr. Tamkin, for a nice introduction. And I know it was at a very short notice, but I will try to do the best I can for speaking on simulation-based learning. So simulation-based learning is actually when we teach psychomotor or procedural skills to our students. And it is very important that we teach them practical skills, which is a vital component of medical education right now. As we speak of competency-based medical education, so psychomotor, practical skills, or procedural skills are very important in today's era. So what is skill? It is the ability to perform a task which leads to a specific predefined outcome. So all these practical psychomotor procedural skill, it requires manual dexterity, especially when we are working in a laboratory or if we are performing any clinical skill. And it involves the ability to use hands in a very skillful manner, in a coordinated way, and we need to manipulate objects and organs of the body and also to demonstrate very precise movements while we are doing procedures or while we operate. So the acquisition of technical skills have been defined into 3 stages by Fitz and Postner. The first is the cognitive phase, where the learner understands and conceptualizes. So he understands the mechanics, the steps of technical skills. He comes to know the indications, contraindications, and the tools which are needed for learning. The next or the second stage is the integrative phase. Here, the learner translates the knowledge of the steps, what he has learned during the cognitive phase, into action. So in the beginning, the movements of the learner may be clumsy while he's performing a task. The third is the autonomous phase. And here the learner performs a specific skill in a competent manner. So he practices until he is able to perform in a competent way the given skill or task or procedure. So let us take an example here, like an insertion of an IV line. So in the beginning, that is the first phase, the learner must have complete knowledge about the procedure. He should know what tools are required for putting an IV line, the appropriate anatomy of the vein, and he should have an idea of the steps. So in this phase, a video may help in providing knowledge. So this is the preparatory phase, which is crucial and accelerates learning. Then comes the second stage, where the learner uses similar hospital equipments and attempts multiple times for practice, and he practices the placement of the IV line on models or mannequins using the same sterile steps which are actually needed during the real procedure. So in this phase, feedback from the instructor or from the peers is coupled with self-reflection. So in this phase, he can get a feedback from his observer or facilitator, and appropriate feedback during this phase will help in learning the right steps. Then is the autonomous or the third stage, where the learner will schedule regular practice time on task trainers until insertion is performed to a level of proficiency, and this translates into real patients. So in this, the learner is competent enough to do it on a real patient. Previously, the learning used to take place by the master apprenticeship model, which basically focused on the development of practical skills in a real world situation from a mentor. So it was like a social guidance when he picked up the skills from his teacher or facilitator, and it was during the work while it is being performed that he learned the skills. So now the master apprenticeship model, that is see one, do one, teach one, has moved on to more structured approaches. So for learning procedural practical skills, there are other ways of learning. One is the Patent's 4-stage approach. The next is the STEPS model, and the third is the SISFR model. So these are more structured approaches for teaching practical skills. So the Patent's 4-step approach also involves cognitive, integrative autonomous phases. So first is the phase where the trainer demonstrates. So all the steps which are required is demonstrated, and this is done without giving instructions or explanatory words. The first one. Then comes a deconstruction phase where the trainer describes the steps and demonstrates all the necessary steps. And in this time, he may divide it into sub-steps so as to explain all the intricacies of the procedure. Next is the comprehension phase where the learner describes the steps while the trainer is demonstrating. So in this phase, the trainer is doing the demonstration and the learner will just enumerate the steps which are involved. And again, in this, sub-steps may be enumerated. So in this phase, a deeper learning is occurring, and as deeper processing mechanisms reflect and what has been observed in the first two steps is implemented. The last is the performance phase where the learner describes the steps and demonstrates. So here both demonstration and description is being taken place by the learner himself, and the trainer will just observe. The next model is the STEPS model. Here S stands for setting the foundation, where the importance of the skill is described in context to the knowledge which may be also given during this phase. And the next phase is the tutor demonstrates without any commentary. Again, no description. E is for explanation with repeat demonstration from the trainer. P is practice under supervision and feedback, and S is subsequent deliberate practice, where he can practice innumerable times before he becomes perfect in that particular skill. So the next is the SISFR model, where again S is setting the context, identifying roles and the outcome. The next is immersing the learner in the roles, and they are allowed to practice for an agreed time. S is summarizing the progress. F is feedback from the tutor, and R is refining practice and then go on to real demonstration on a real patient. So these are some of the ways of learning practical skills. Next, we move on to the skills lab. So a skills lab, which is now mandatory in any medical college. We have also started one in our medical college, and this was in 2019 that I was able to start in our medical college with the help of the administration. We have the models, mannequins of various fidelities. One could be a low fidelity or a moderate fidelity or a high fidelity skill lab. So here, because a simulated environment is required, is actually given to the learner, so it addresses patient safety because he does not practice on a real patient itself. So here we are providing a safe environment to the learner for practice and allow him to make errors. And the learning is occurring in a non-threatening environment. So the learner is allowed to practice as many times as needed and then go on to demonstrate it in a real patient. Here also you can deconstruct the skill. You can break up into sub-steps and then help him to learn. Again, here technical skills are learned because the basic knowledge is given pre-hand. The skills are taught, and also it helps in behavioral learning because here he's working in a team many of the times, and he's picking up non-technical skills as well, like leadership, teamwork, communication between the members as well as with the facilitator. Also, feedback from learners can be given, or a video recording can be done where certain issues can be dealt later on. So here in a skill lab, we allow them for a deliberate practice, and evaluation also can be done on these skill labs or simulation labs. So this simulation based teaching is basically on artificial representation of a real world process. So we are providing an artificial simulated environment. And this is basically to achieve educational goals through experiential learning. So this is learning by experience. So learning by experience is not occurring on real patients, but on models and mannequins. So this has three components. One is the deliberate practice, which is done by the learners, reflection and feedback from the facilitator. So it is an educational activity that utilizes simulation aids to replicate clinical scenarios. So what is deliberate practice? When the learner is allowed to repeat and practice, and assessment of the skill is also done side by side by the facilitator. Specific information in the form of feedback is given, which increases his performance of the skill. So there are various skill labs which are available, and as I said earlier, it can be of a low fidelity or a high fidelity skill lab. And the simulators are basically classified into different categories, and accordingly you can go on to have simulation or skill lab activities. So what are these low fidelity models? They are actually static and they lack realism or content to the situation and clinical scenarios. So they are used to teach basis of technical skills to the beginners, such as an intravenous arm. The one which we have for teaching how to put an IV line is considered as a low fidelity model. And also some the resuscitation models that we have where we can practice CPR. Some of them are of low fidelity, while some may be of a moderate fidelity. So efficient training may be required, and especially this is for the new beginners where they practice on these low fidelity models. The moderate fidelity are like the Harvey cardiology simulators. So these simulators give more resemblance of reality, and in clinical situations, they may have features like it can mimic pulse, heart sounds, breathing sounds, but without any ability to talk. And they also lack chest or eye movements. So this is in context to the CPR models that I'm talking, which could be of moderate fidelity. So some of the human characteristics may be present in these types of models. The high fidelity simulation is when a combination of mannequins which carry tasks with computers and produce signs and mimic clinical situations and scenarios. These can also talk, breathe, blink eyes and respond either automatically or manually. So these are mostly computer linked, and the examples can be like a human patient simulator or the Noel obstetric simulations, which are computer linked. So all the talking and the actions are actually basically done all computerized. So, but we should remember that higher the fidelity of the model, the more expensive it is. There are also some wet labs which are available, a place where cadaveric or animal models are used for training purpose. So the cadavers may be either full or partial, may be used depending on the educational objective. So sometimes like we can practice suturing of the bladder. The pig bladder is also available. I've been to a workshop recently before the COVID era, and the bladder was used for suturing and teaching how the students can do bladder repair surgeries. So these wet labs can be of in vivo animal models or ex vivo animal models, in which animal organs like bladder, intestine, etc. can be done. Use of an umbilical cord is also very prevalent, and especially after the delivery from the placenta, suturing of umbilical vessels under lens is an effective way to teach tubal recanalization surgical methods. What are the limitations of these wet labs? Because of the ethical concerns where the animal anatomy is not easily available, and especially nowadays, human anatomy, it may not resemble, and therefore there could be defective learning also. Then there are dry labs also available, and this is similar to surgical simulation lab where the learners practice procedures on trainers or models. So one of the examples is like the endo trainer, where you can learn extracorporeal, intracorporeal suturing. So all these simulators can only imitate but not replicate reality. Then there are some patient simulation labs also. These are more realistic and more interactive. And here we use standardized patients. They are also called as simulated patients or persons, and these are actors. And they are playing the roles of patients. They are coached to some specific illnesses, and a person who's trained to portray a patient in realistic and repeatable ways. So these standardized patients, they act the clinical scenario, and the learners can learn again. So what are the limitations? Again, actor training and availability is an issue. Reproducibility is again a problem, and cost of implementation. And besides being realistic and interactive, patient simulation labs, the learners learn how to take decisions. Some of the clinical decisions can be taken during the running of the clinical scenario. They also learn non-technical skills while they are interacting among the peers while performing on standardized patients. Team training, group dynamics has to be maintained while the clinical scenario is being run, and therefore it builds up the non-technical skills. Clinical scenarios or procedures at high risk, which are infrequently encountered, can be practiced in a controlled environment. So these simulated participants who play a role of family members, sometimes these learners can also learn how to cope with difficult situation, counseling and communication through these simulated or standardized patients and relatives. Then it could be a virtual computer-based simulation where the computer-based activity is done, where students interact with an educational activity via a computer interface. So a virtual environment resembling clinical real life situation is created with the software. But for this, we need IT support. So again, it becomes little difficult in a day-to-day practice to set up these clinical scenarios. So each model, which is low or high fidelity, should have a module for training. And the module should include learning objectives, method of teaching and assessment. So it is not like that a learner would go into a skill lab or a simulation lab and start practicing there. But as facilitators, one needs to define the clinical learning objectives, the method of teaching, and also how to assess. The modules can be hybrid modules, where real patients or standardized simulated patients can be combined with computer software-based simulations. So whenever simulation-based models are used, we need to incorporate some characteristics into the module. These are actually the plastic modules, which I have already spoken about. This is the partial task trainers. This is mainly used for training in basic clinical skills, like I said, IV line arm, and the examination of rectum, breast, which can be demonstrated on these plastic models. So these are low fidelity models. Clinical procedures such as suturing, catheterization, then insertion of intrauterine contraceptive device can be practiced. These are the low, moderate, high fidelity models. So again, these are all computerized models. So while we are doing simulation-based teaching or learning, there are certain procedures which need to be fulfilled to attain the competency which we want the learners to learn. The first is to identify the task, what competency we want to teach. Next is training the objectives. Training objectives should be defined, well defined. And then we need to select appropriate training tools to meet these requirements. The task is demonstrated, and then the learner is allowed to practice and rehearse, guided by immediate feedback by the facilitator or the peers, and the learner is allowed to fail and learn from his mistakes during these practice sessions. So why we need simulation-based learning in obstetrics? Because we know that obstetrics is a high-risk specialty. It requires availability of skilled workers. Not only it requires education, training, but more importantly, it requires clinical experience, and especially to prevent, detect, and manage complications in our field. So, and because of the sensitive and often emergency nature of obstetrics, many of our students become just observers. And because the vast number of students that we have in our colleges, and we are not unable to give them hands-on training. So therefore they do not acquire a functional role during the day-to-day teaching. The doctor trainees learn the clinical skills on the job. So while assisting and performing procedures, they progressively get involved into more and more complex tasks. So that is the time that they learn while they are assisting us. So we need to change this. And now, because of increasing awareness of patient safety and ethical concerns, there's greater emphasis on operating room efficiency, which involves clinical and motor skills. So that is the general need of simulation-based learning. And since there is more emphasis on competency in our operating room efficiency. So this may not be applicable to the undergraduate, but definitely for the postgraduate students. So I will give an example of the simulation-based teaching module that I built up in my department. And this was for the active management of third stage of labor. So the first thing that one needs to do is to set up the clinical scenario. So this is not the labor room setup. Actually, it was a room in a medical education department where we thought of simulating active management of third stage of labor. So we put up the requisites which are needed for after delivery. We have the low fidelity model, which you can see in the picture, and we modified that. So we put in some red color fluid into it to depict blood. Then we have to identify whatever the instruments needed during the active management of third stage of labor. And we also put up a table for the baby. So all depicting a normal delivery room. So when we start simulation-based learning, briefing is very important. Once the clinical scenario is defined, briefing. So briefing should take around 10 minutes, then running of the clinical scenario, and then debriefing. Debriefing is the most important part of simulation-based learning, where the learners learn what went wrong during running of the clinical scenario and what could have been done in a better way. Briefing is actually where the learning objectives were defined. So at the end of the session, each participant should have been able to describe the three components of active management of third stage and also demonstrate the clinical skills for performing this task on a mannequin. Then after the briefing, that is during briefing, we also tell them that these are the instruments and these are the medications which could be needed. Everything is well defined before running the clinical scenario. The clinical scenario which we gave was Mrs. X delivered vaginally, which was uneventful, and the vaginal bleeding was average, no complications. And after the delivery of the baby, they had to perform active management of third stage of labor. So this is the model which we made. As you can see, during the running of the clinical scenario, it was shown that blood is flowing out. So really simulating the real life situation that one faces in delivery rooms. So this was a setup again, and actually these are the postgraduate students of my department, and they were given this clinical scenario. So I'll just run a short video of what happened. So this is the briefing part, and in this we introduce ourselves. Actually, This is a formality because I had to make this video. So here we have to define the roles. They will be the observers. I am the facilitator, and one of them will have to run the clinical scenario and identify other assistants. So after describing the learning objectives, we move on to the model and the clinical scenario. So they were told what task is required to be performed, the equipments, the instruments which are needed, the medicines, everything was set. This is again a side room in a labor room where a delivery room setup was done, simulating a real delivery room. So after the briefing part, they were asked to perform the task. So here they are identifying their own roles. One would be the physician, obstetrician, one would be the assistant, and one would be the neonatologist. So here they have defined their roles, and now they will be running the clinical scenario. While she's demonstrating, she's also explaining to the observers. So how a uterotonic drug is given. Though the postgraduate students, they are allowed to perform on real patients, but I think for the undergraduate students, when before they move on to a normal delivery procedure, I think it would be good to have them learn and practice on these models and mannequins. So here, like a control cord traction, which is showing to the rest of the students and learners. Uterine massage, which is the third component of active management. Examination of the genital tract for any injuries, tears, and then comes the examination of the placenta. So the placenta also, like, we had to modify that and put up membranes. This was done using a plastic bag. How to examine the placenta after delivery to see the completeness of the cotyledons and the membranes. So with this, they completed the task which was given to them. Then comes the debriefing part. So in this debriefing part, we need to discuss how the clinical scenario was run, a brief description of what happened, how it went, what could have been done better. So this debriefing part is very important because it facilitates learning. So feedback from the facilitator. And with that, we completed the simulation. So as I said earlier also, these students, learners can be allowed to practice, and we need to define practice checklist also, whether they are performing it in sequential manner, and any step which has been left or missed can be marked. So this practice checklist also was made. Then assessment of the clinical skill can again be performed by direct observation of procedural skills, that is DOPS. Evaluation checklist was made and validated by other professors and faculty in the department. So every time assessment is done, a checklist is kept so that we can mark accordingly and see whether it has been done stepwise. So simulation-based teaching should be an integral part of competency-based medical education. Simulation aids to replicate clinical scenarios. It is more structured and is performed in a controlled, non-threatening environment, allows hands-on training, patient safety is there, no ethical concerns, but it also addresses depleted resources in the form that when patients are not available, where the patient load is less, and also prevents any medical legal litigations. It also helps to build up interpersonal communication while they are performing the task, helps in teamwork, leadership, decision making, and also an ability to prioritize tasks under pressure, helps in stress management, improves confidence in performing life-saving skills, clinical skills, and communication skills. But there are some problems also, because it does not completely mimic human systems. So there could be defective learning, cost factors involved, time also is required, the infrastructure should be there, and sometimes we face technical difficulties as well. Training through simulation should be not viewed as a complete thing. It is an adjuvant and not a replacement for learning with real patients. So it has to go side by side with learning on real patients. But it is a requirement for today, because they can practice well and then go on to real patients, and when they are more confident. So this was all about simulation based learning, which I had from my side.
So thank you very much, Dr. Kavita. Can we have your video on, please? So that
Yeah. My video is off.
yeah, I was unable to see your video. I didn't want to disturb you in between. I don't know
Okay.
others. Yeah. So now from the other attendees, any questions, please raise your hands. I can't find any questions in the uh, question box. So anybody who would like to, yeah, Dr. Anjali, I have unmuted you. Dr. Anjali. So please share your experiences and your ideas about how to, develop low-cost models for simulation-based learning.
Ma'am, am I audible?
Yeah, you are
Hello?
audible. Yeah, you are audible.
Yes, ma'am. It was a wonderful session, and even we have been trying to do something similar to simulation, like making out of pellets, making something quaternary reaction, putting rubber tubes and making them red and blue.
Okay.
Dr. Anjali, your voice is not very clear. It's breaking. Dr. Anjali, can you repeat what you said, please? And others, please, would you like to share your experience about simulation-based learning? Any low-cost models that you people have tried? What topics have been taken at your institute? Okay, Dr. Pushpa. Dr. Pushpa, your hand is raised. Dr. Pushpa, you can talk. Unmute yourself and talk.
Yes. Good evening. We have similar experience with active management of labor during a PPH bundle project. In this, the interns and the final year students also were included.
Okay.
So that basically included this insertion of balloon tamponade. But before that, just like Kavita madam has demonstrated, we had demonstrated active management of labor with more things included. That is all the uterotonics and all those. But in this, I am having a doubt. That is, doing this on regular basis, will it be useful for undergraduates, or it is basically for postgraduate students? That is whatever madam has demonstrated or in that video.
Yeah.
So, Dr. Kavita,
Yeah. So when we have undergraduates coming to us in our department for their postings, they are not more than 20 students at one time. So this is done actually during the clinical posting time. So we have a batch of 15 to 20. So it is quite feasible during that time. And since I have already trained my postgraduates in this, they can, under supervision, they can also take classes for them, for the undergraduates. So maybe the undergraduates may not be able to practice, but they can always come to the skill lab. It is open from 8 to 5, and we have people there to monitor them and help them. So they can come during that time whenever they are free and practice these sessions. So it is not impossible even for the undergraduate students.
Okay.
There are difficulties are there. It is very time consuming, but it can be done.
I think especially simulation-based learning has more application for the undergraduate, because teaching is a more, sort of, should I say, use the word risky, and you need absolute supervision all the time. Whereas on the model, once you have taught them, shown them, demonstrated them, and deconstructed those steps, they can continue to practice, and they can use that, each one teach one, that can go forwards. Because that risk to the patient's life is not there. And that is
Yes.
the reason why it's called more humanistic training. They are first acquiring that skill, and later on only they are actually practicing on the patient.
We have also made up a module on female catheterization. So,
Dr. Anjali, can you mute you? Dr. Anjali, would you like to repeat what you were saying? Or please mute yourself. I'm unable to mute you from my end. Okay, Dr. Kavita, you were saying something.
yeah, I was giving an example of a module that we have developed that is for female catheterization. It may not be for undergraduates now, but just an example of another module that we have made. So it may be useful at the post level. But actually, our institution, some of our candidates who go and serve in the remote areas of India. So in those special internship, we have to teach them these basic clinical procedural skills. So, and obviously, I think everywhere in internship, they're learning how to put in IV lines, catheterization and all. So these modules are required now. And during the internship also come and practice on these models, mannequins, and then go on to patient level. This
Good
actually
evening, Dr. Tamkin.
can be ongoing.
Good evening.
Dr. Tamkin, can I come in?
Sure, sure, Dr. Anand. Yeah.
No, just this was a really wonderful presentation by Dr. Kavita. My congratulations to her. And
Thank you. Thank you.
so, about the question as to whether it is applicable to undergraduates or not, there is a simple answer to that. The answer being that in the competency based education model, we have been given our competencies in OBG. And also, we have been given a list of psychomotor skills that the undergraduate needs to learn. And as Dr. Kavita rightly pointed out, there is IV cannulation is also one of them. Catheterization is also one of them. So it is it's now that we don't have a choice. We have to teach our undergraduates these things. And when we look at the competencies in the OBG curriculum, we will also find that active management of third stage of labor is one of the competencies that are there. So it leaves us not much choice, because if this competency has been included, it has to be taught. Because again, as said earlier, competency is not just the knowledge acquisition, it is the knowledge plus the skill as well as the attitude, everything combined. So for that part, when we talk about undergraduates and postgraduates, we have to go back again and again and look at the module, look at our competencies that have been given to us, and there will be the answers as to which are the competencies that the undergraduate has to be taught. The other another thing that I wanted to come in here is about something that is being emphasized in competency based medical education is algorithmic practice, meaning you have an algorithm, like suppose and it is very scenario based. It says that a lady has delivered, let us say, an hour before, and then she starts hemorrhaging. So how would you manage her? And in that algorithm you will get all the the sections of the pph, atonic, and traumatic, etc. And that also could be a way of developing critical thinking skills. And it could be very well a simulation based as well. So there are so many dimensions to this thing. And again, we have to, if we want to incorporate all these things, we have to go back to our competencies and see that yes, this is a competency that has been specified by NMC that the undergraduate needs to know. That's all, Dr. Tamkin. Please go ahead.
Okay. Dr. Manjeet Mohi, I have unmuted you. Dr. Manjeet Mohi. We want more
Yes, thank you,
experience.
ma'am.
More,
Yes, thank you, and good evening to everybody. And I congratulate Dr. Kavita for an excellent presentation. Because it is CMC Ludhiana and can afford to have good skill lab, I really like to come and see it. As far as my experience is concerned, Punjab government has given Mama Natali to every medical college and every training center. So in that Mama Natali, they have given a very nice model in which PPH, how to manage PPH is taught. That is one which has been effort given, done by the, I think it was by the government of India and incorporated by the government of Punjab to all medical colleges. Hello?
Yeah.
We
Am I
can hear
audible?
you. Yes.
Yes, you were audible. Yeah.
This
Dr.
is what I
Manjeet,
wanted to
please.
convey. Yeah. This is what I wanted to convey to everybody that at the level of GOI and Punjab government, they have really supported for giving training for the management of PPH.
Okay. Thank you. Dr. Binu. Dr. Binu, I have unmuted you. You've typed a question. Can you just ask your question here? Dr. Kavita is there to answer. Dr. Binu. Dr. Indra.
Hello, ma'am. Binu here. It was
Yeah.
really a wonderful talk, ma'am. I just wanted to know if there is any forum or website available which can provide us with these model evaluation checklists, so that we could bring some sort of standardization across the institutes. I mean, in India or somewhere else. Is there any platform available where we can find them from?
Yeah, I
Can I
think
answer this?
we have.
Can I answer this question, Dr. Damki?
Yeah, please, ma'am.
Okay. See, Dr. Meenu, if you goes to the ACOG site, that is the American College of Obstetrics and Gynecology, you will find a lot of checklist. You will find a lot of
Right,
checklists.
right.
So in those checklists, you will find a checklist for a previous cesarean, for a
Mm-hmm.
elective cesarean, emergency cesareans, a checklist for
Mm-hmm.
induction of labor. Hmm. They
Mm-hmm.
may not specifically be absolutely tailored to our competencies, but
Yeah,
you can,
exactly. They are more
you
for PGs, I would say. I mean, at UG level, they are not that much. I
no, but
mean,
what you can do is take out some parts of that and make
mm-hmm.
out your own checklist. And of
Mm-hmm.
course, when you're making a checklist, Dr. Binu, you will first have to see the competency, because the
Yeah, yeah,
competency will be broken down into objectives, and each of these
yes.
objectives will be
Could
sort
then
of
be
each one point in
converted
the
to yes, yes.
yes, yes.
Mm-hmm.
Maybe that one objective has four points in a checklist, or maybe one objective has
Right,
1 point in the checklist, whatever it may
right.
be. So now we have to tailor it according to our own
Mm-hmm.
competencies and objectives there.
Yes, yes,
So
yes, yes.
yeah, maybe we all together have to make some checklists, which will be
Exactly, ma'am.
our own needs, our own needs.
Yeah, yeah, yeah. I was just thinking of if it is there at any other site or of some other country, maybe, which we could use as a basic structure, basic document. I mean,
Kavita,
If
you
you
would like
look
From
to
at
add
some
something?
Foxy also has given
Hmm.
some checklist. And as
Right,
I told
right,
you, algorithmic managements, when you see,
right.
let us say you see there is a standard book in obstetrics like say DC Datta, huh?
Yes, yes.
Which is used by many of us, and there may be certain other books also. We will find certain
Mm-hmm.
boxes there where you will find
Mm-hmm.
that above 32 weeks of pregnancy, below 32 weeks of pregnancy,
Mm-hmm.
IUG,
Mm-hmm. Mm-hmm.
you will certain things like that. So you can
Yeah,
borrow from there, and but
right.
basically
And
our
make our
our
own, yeah.
yes, yes,
Mm-hmm.
yes. Because it
Mm-hmm.
will not be absolutely replicable in every circumstance. However checklist you make, you will have to
Mm-hmm.
improvise for your own context.
Mm-hmm. Mm-hmm. Right,
Uh,
right, ma'am. Thank you so much.
Dr. Kavita, would you like to add something to that?
Yeah, I wanted to add here that what I made that checklist is from the WHO standard. And many of the things like Dr. Amita was saying, we have to tailor it according to our needs. And we did that.
Mm-hmm.
And to validate that, I involved the other faculties as well, the professors of our department, so that we follow a standard checklist in the department. So like that, we can develop and see what our needs are for the postgraduates or for the undergraduates.
Okay.
Right, right.
Can I,
Thank you so much, ma'am.
Dr. Binu, there's a whole a book on emergency obstetric care. The latest
Mm-hmm.
edition is 2019, in which you have
Mm-hmm.
most of the undergraduate, most of the learning guides for simulation-based learning that you need for
Mm-hmm.
this thing for undergraduate teaching. And at the same
Right.
time, they have a trainer's manual for emergency obstetric care. And the
Mm-hmm.
trainer's manual contains all those checklists as well. And I will share the link.
Right.
It is freely available.
Yeah,
I will
please do
share the
that, ma'am. Please do that.
and they are beautifully made learning guides, and we have been using them for a long time for both undergraduate teaching and for training medical officers in emergency obstetric care. So I'll be sharing
Right,
that, and you
right.
can. And it is any learning guide or a checklist cannot be a
Mm-hmm.
static thing. It has to be a dynamic thing.
Yeah,
You
we'll
need to
have to
keep on,
improvise that. Yeah, yeah.
because as you have new evidence coming up, isn't it?
Mm-hmm.
Earlier, for
Yes,
example, we could be giving the syntocinon at what stage?
yes.
At the delivery of the anterior shoulder. Then it changed after the
Mm-hmm.
delivery.
Mm-hmm.
So you need to revise that learning guide as well as your checklist. Checklist is the one you will use for the assessment, whether they are doing it
Yes,
okay. Learning guide is
exactly.
the one which will have more steps and more details, breaking the
Mm-hmm.
task into
Mm-hmm.
smaller tasks. So, like Dr. Amita
Mm-hmm.
said, I'll share
Mm-hmm.
that link with you.
Right,
it is
ma'am.
going to
Thank
be.
you so much, ma'am. Thank you so much, ma'am.
Dr. Indra, you are unmuted,
Hello.
Dr. Indra.
Hello. Am I
Yeah.
audible, ma'am?
Yeah.
Hello. Hello. Good
Yeah, you are
evening,
audible.
everyone. Yeah, ma'am.
Mhm.
I just wanted to share a small experience from our institute. Recently, in the COVID time, actually, our hospital was converted into a COVID hospital, and the obstetric work has already come, has come to a standstill. So, in fact, we started the skills lab actually training for the house surgeons actually because they were missing the deliveries and other things. For the existing batch, we have divided them into small groups, only eight students, and for several days, over a period of several days, we have conducted this program for them. And we had 4 stations. One was about cervical dilatation and station of the fetal head. And in the second station, they were shown, and later on they were allowed to do the delivery also, delivery of the fetal baby. And in the third one was about PPH, and the fourth one was eclampsia drill. So actually what we found was the students really enjoyed this learning, and the satisfaction rates were very high with the skills lab actually. Rather than didactic lectures, the students also started enjoying this very much and showed a lot of interest. And we also had a small questionnaire and a pre-test and a post-test and also a feedback. And they have requested for more hours of skills lab training in our program. So this was like, we just started like a pilot project. We just wanted to see how it would roll out. So we did this in the COVID time. And so maybe students will be definitely benefited, and the faculty also needs a little bit of training, and all the faculty should take interest in teaching. Then only this will happen actually successfully. And one more thing, madam, now in the current CBME program, now some topics competencies have been given as skills lab training. So do we take these classes there, or show these skills in the skills lab itself in the regular clinical hours? And in which semester students can we include? Like, should it start right from third sem, or from the 7th or 8th semester?
Dr. Kavita.
In our institution, we start in the phase 2 only, phase 2 students. They come to us, and now we are talking about early clinical exposure. So all the more need that they are shown first in the skill lab and then shown in the real wards. So even for deliveries, we have a mannequin which is also electronic. So the first delivery, first 2-3 deliveries we show on the mannequins, and then we take them to labor ward. So phase 2, when they come to clinical exposure, that can be done.
Okay, ma'am.
So,
And one more thing, madam, do we have
Can
to
I?
have only high-end models, like, or is it okay if we have low fidelity models, like, initially, especially for the undergraduates? Maybe
Yeah,
for
for the
PGs,
beginners,
high-end models will be good.
I said low fidelity models where the cost is also less, and
Yeah, maintenance is
they,
easy actually,
and they don't have to
so
really be precise, when they're performing it, because they are still learning steps
yeah.
initially. But for postgraduates and all, I think it is more of that is
Uh,
required.
Okay, ma'am.
can I just come in here a little bit?
Thank you, ma'am.
yes, Dr. Amita.
So, trying to answer, I do not know, doctor who was there who asked the question about when to teach the skills. Can I please have the name again?
Dr. Indra.
Dr. Indra. So what Dr. Indra, I wanted to tell you is this, that as regards the timing, you have to make sure that you are doing it progressively with increasing complexity of the task. Like, whenever a task has to be performed, there has to be first a theoretical basis given to it. So I think whenever you are talking about skills, showing skills to undergraduates and making them practice, etc., you must make sure that the theory of the skill has come before that, and after that you build it onto that. So progressively the level has to be increased, and when they come in the third, when they are the early clinical exposure, then immediately during the early clinical exposure, or let us say the first session of the early clinical exposure, it would be very difficult to teach them a skill because they are just raw and they do not have any theoretical basis for the skill. So I think during the early clinical exposure, it would be better to build up the theoretical knowledge. And after some time, when they are quite conversant with the steps of the procedure, or the why the procedure is done, what could go wrong in the procedure, etc. When I've got that basic knowledge, then you could go ahead and actually start teaching them the skill step by step and making them practice. And then, of course, build up the complexity of the skill. That's it.
Okay. So any more questions? Dr. Bino already answered. Any more experience sharing? Any more questions? Or shall we just finish now? I would just like to add that whether the model is high fidelity or low fidelity, what is more important is that the way you are using that model. And like Dr. Kavita said, it has to be a planned session with a briefing, and then a clinical scenario is played, and then most important is the debriefing. I think that is the take-home message, most important, that I got from her lecture. And apart from that, the students should also be told about the care of the models and how to handle those models. And because it is your simulation of a real situation, while they are handling the models, they have to take care of all those things that we keep, because we are at the same time, we are trying to teach them communication skills, infection prevention practices, covering the patient, taking care of the privacy of the patient. It is simulation of a real life scenario. So while we are teaching them, also we should emphasize on that. And while we are making the checklist for the assessment, this important point should be included, and the students should know that they will be, when they are being assessed, we are going to examine them on these points. And it is always better to have the, a scrubbing station, maybe just a photograph of a tap is there, and some sanitizer is kept there, the gloves, the way they are wearing the gloves, that how they are doing it. So all those points should be included in the checklist and in the learning guide, and then only it is going to be a simulation based learning, and then only they'll be able to replicate all those points in the actual when the patient encounter. So that is very important. Dr. Kavita,
and Dr. Tamkin, I'm very glad you brought out Dr. Tamkin, I'm very glad you brought out the glove wearing part of it, because many of us omit this part. Wearing the gloves takes 5 minutes, then how you're going to control the pph? By that time the patient may have bled a lot. So actually I think you've raised a very, very pertinent point, that wearing the gloves is the first step that has to be taught to any person who's going to handle pph, and then go on to the pph steps actually. So wearing, I've seen so many students, they are fumbling when they are wearing the glove, they are taking so long a time, they don't know the correct technique. So basically for undergraduates, we should focus on these very, very basic things: wearing the glove properly, sterilizing the area, washing the hands, all the steps of the hand washing. These are very important before we go on to actually tell them the skills.
Yes, the BMW, the post documentation.
Absolutely.
And assessed, then only it becomes a reflex with them. So thank you, Dr. Kavita, for a very this refreshing session for all of us, and a very good beautiful weekend treat for us, and especially for being so generous and sharing your module and your wonderfully made video with all of us. Thank you so much. Dr. Amita, would you like to add something? Or we can
no, thank you very much. That was really, again, I would echo your sentiments. And when are we doing? Are we doing a logbook session? Maybe what we can do in the logbook session is actually choose those skills which we really want to put into the logbook and assess the students on.
Dr. Amita,
are we doing a logbook session? Yeah.
Yeah, I was thinking of having a discussion based logbook session completely, let's take inputs from everybody, and then we write down those inputs, and then we have that logbook, finalize that logbook.
Yeah, no, what we could do, what I was thinking, if you all agree, that first of all, let us have a little 3 or 4 or 5 slides, which tells everybody that this is the essentiality of the logbook, because the logbook has been framed under certain guiding principles. So let us first know these guiding principles under 4 or 5 slides, or maybe even 6 or 7 slides. And then we can have a Google form where we can ask all the people to give their opinion as to which are the competencies they would like to see in the logbook. And right after that, we could have a discussion.
So the competencies that have to be included, I think they have already defined in the document.
Yes, they have.
So
but can we include all the competencies?
No, those particular objective, sorry, the competencies for the logbook for the interns are different. They're already defined, and we have to make objectives out of those, and then we need to describe how they are going to document that they have learned, how we are going to assess them. That's what I went to that.
No, that's what we actually, it's for the undergraduates. I think they have said the things that to be included in the logbook are not the knows competencies, but at least the knows hows, and preferably the shows competency. So I think according to that, we can choose our competencies to be included in the logbook.
I think we'll all go through that document, the logbook document that is already
Yes,
there.
yes, absolutely. So everybody should go through that, and then we can decide, because there are so many competencies, and many of these competencies are only knows, to the level of knows. So we need not include them in the logbook. I think we should include those competencies in the logbook which are at least knows how, or better still, all the shows how competencies.
Dr. Amita, for the interns, they have already defined the competencies.
No, we are talking about the undergraduates.
So we are not talking about the logbook for the interns. We are talking about the logbook for the undergraduates. Okay. So what we can
for the undergraduates.
Okay. So yes, we can have a discussion. I think that will be very fruitful. So we can have a discussion-based session on that.
Sure.
Isn't it? That's what you.
Yeah. Firstly, a little bit about the principles which have been framed for the undergraduate logbook, and then people can discuss as to which one has to be included. And again, before we do all that, everybody has to go through the competencies and see what are the competencies that have been asked to be included in the logbook for the undergraduates, not for the interns.
Okay. I understand.
Yeah.
So the next 2 sessions we have already decided are related to integration, and they are very
integration.
Because that is something. The rest of the sessions were on subjects that we were already doing to some extent, but this is something absolutely new, new to us, and how to execute that integration based learning. So next 2 sessions are very important. I hope all of us will be there and join. I think Dr. Pushpa wants to say something.
Yes, yes, ma'am.
What
I wanted to make clear is, according to that MCI certifiable competency, only conduct of normal delivery is labeled as certifiable in a subject. But there are many things we want that undergraduate students should know.
Exactly, Dr. Pushpa. Exactly, Dr. Pushpa. That is why I said that certifiable skill has to be included in the logbook. That has to be there. But apart from that, we all have to discuss. That's what you said. You would like to see certain competencies. Similarly, I would definitely like to see certain competencies there in the logbook. So that is exactly what we have to come to a consensus about, that besides the conduction of the delivery, which is a certifiable skill for every undergraduate, we'll have to choose certain other competencies which should be included in the logbook.
Exactly. Yes.
Exactly. Yeah.
So we'll plan that logbook session in that manner, Dr. Amita.
Yeah,
Now
we'll
just and good night, everybody. Have a great weekend.
Okay, good night. Good night.
Bye.
When is the next session, madam?
Next Saturday. I'll put it on the group.
Okay. Okay. Thank you.
Okay.
Thank you, ma'am.
Bye-bye. Thank you.